Many of us in our modern world have never seen anyone dying and don't know what it looks like. Many people are fearful that death is inevitably accompanied by suffering. Most deaths are actually very comfortable, especially with palliative care interventions. People start getting weaker and weaker over time, start resting more, and eating and drinking less. Then, in the last days or weeks, they start sleeping more and stop eating or drinking, and finally slip into a sleep or unconsciousness. This is followed by a peaceful death. Some patients may experience confusion or agitation at the very end of life in the last hours or days. If this happens, we have treatments to help so that they are kept comfortable. If pain or shortness of breath were to worsen in the last hours or days or weeks, we have pain medications that can help, and we can adjust the doses to have the patients comfortable without sedating or shortening their lives. Sometimes, death may come quicker than expected, or a person may be awake and go into a breathing or pain crisis suddenly. This, for example, can happen if there are large blood clots that go to the lungs. Again, in these cases, there are palliative care interventions to reduce suffering. It is important to know that at the end of life, one's breathing patterns may change, and these are normal, and not necessarily signs of suffering. One of the most common normal patterns in the last days or hours of life is called chain Stokes breathing. In this pattern of breathing, the breathing slows down, becomes shallower, and then seems to stop for a long time. And then the person starts breathing again, speeds up, and then starts slowing down, and then stops. And so the cycle repeats itself. Another normal pattern is called agonal breathing. In this pattern, the breathing stops for many seconds, and then the person takes a sudden deep breath, breathes a little bit, and then stops again for many seconds. The cycle continues until the breathing stops for the last time. When this is happening, oxygen is not needed if the patient was not experiencing shortness of breath before and was not requiring oxygen before. In patients who were requiring oxygen because of shortness of breath, because of lung disease, we continue the oxygen during these cycles. Other signs that death is coming soon, within hours or days, is coldness of the hands and feet and mottling, blue markings of the skin. The pulse becomes weak and the patient starts losing consciousness. Some patients experience what we call airway secretions. They are generally mild gurgling sounds that come from the throat. They are caused by phlegm building up on the back of the throat. We all produce phlegm on an ongoing basis, and we swallow that phlegm. At the very end of life, when death is near and the person is too weak to swallow, the phlegm builds up in the back of the throat, causing these sounds. Most of the times they are mild or moderate, and they don't cause suffocation. It's like snoring. Snoring is bothersome to the person who's listening, but not bothersome to the person who's sleeping. So when they are mild, they do not need any treatment. If they are moderate, simply placing someone a little on their side can help. If they are severe, we have medications that can reduce the secretions. Since most patients will not be able to eat or drink in the last days or weeks of life, and some may experience complications like confusion, it is important that we prepare for these possibilities, especially if the patient is being cared for at home. To prevent crises and to avoid rushing a patient to an emergency department or hospital unnecessarily, it is important to plan ahead with one's doctors, nurses, social workers, and the team. Find out who to call and what the 24/7 telephone numbers are to reach the home care nurse or doctor in case of a crisis or when help is needed. Also ensure that a Do Not Resuscitate Order, or DNR, also sometimes referred to as Allow Natural Death or A&D, is in place, and that all healthcare providers and the family are aware of it, so that at the end 911 is not called. If 911 is called, they will proceed to do CPR and intubation and administer electrical shocks, even if that is not the goal of care. With planning, one can avoid crises and also deal with them better should they occur.